right, today we're going to talk about mitral and tricuspid TEER, the imaging both on echo and fluoro. So this is the first time that we actually draw a parallel between the procedural imaging for mitral and tricuspid TEER, and I think doing this will really allow you to correlate one versus the other, because we need to really standardize the procedures to make it highly efficient. So I'm going to draw a basic view here, and we'll separate between mitral and tricuspid so we can actually see the parallel. Okay, so and then because of space, I'll draw it in this manner. So first, we know that the mitral side, what is your most common view to grasping? So first, we have the intercommissural bicommissural view, right? So first, we have this, right, with the LV. And this is kind of your intercommissural view. This is your left atrial appendage, and this is kind of on your septum. Okay, so when you scan for the anatomy, you do a sweep, right? Going this way, and then you sweep along from lateral, right, to medial. So far, so good? So you can sweep this way or this way, it doesn't really matter. But what you're trying to do is, if you go back to an X-plane now, here's what you see, right? So if you're in the middle, this is the aortic valve. This is your anterior mitral leaflet. This is the posterior leaflet. That's your, right? So this is P, this is A. Okay, and this is your LV, of course. This is your LA. So you are sweeping from one view to the other to check for the anatomy, the pathology, and also what your leaflet lengths are, so that you know exactly where to grasp, and also you can see how broad the jet width. Okay, so now let's translate to the tricuspid valve. What view do you need to see? So this will be the RV inflow, right? Okay, and it can be in the mid-esophageal or deep esophageal view. So just to go back, this is the bicom, which everyone knows. And then this is the LVOT view. Okay, so the RV inflow, what are you looking for? You're looking for basically the tricuspid valve, right? With multi-segment, this is usually where the aortic valve sits. And so what you're looking at here is anterior, right, and stripping posterior. And so you can see this is the image you're looking at, right? This is the RVOT view, outflow tract here. So this is anterior septal, and this posterior. So what you need to make sure is that when you beam, you're beaming across this way. So here on the mitral side, typically you will be between 60 to 90 degrees, depending how the heart is rotated, and you want to make sure your apex is 6 o'clock. Here, most of the time people say it's 45 degrees, okay, but actually you might need to go all the way to 70, depends again how rotated the RV is, because you don't want to have the beam crossing the aortic valve, okay? So let's just give you an example here. I'm going to erase this for a moment. If your aortic valve sits more in the center, and you do the same kind of inflow view, your beam is here. If you're going commissural, you're going to beam through the aortic valve, okay? And you're beaming through here, and you're beaming through here. What happens is that, remember, the device has to be perpendicular to your annular plane, just like here, right? Okay? So if your device is here and your beam is oblique, what happens? You will only beam across certain part of your clip. So either the bottom portion or the higher portion. So you're not going to see the entire clip in terms of your orientation and also checking the grippers. So that's why you need to what we call stand up the inflow view. So when you stand up the inflow view, you then have the aortic valve shifted here. Your beam is now more center, and then you can beam in a more perpendicular manner because usually we're grasping at the center of the valve, okay? So now you can see that I'm perpendicular. Does that make sense in terms of the similarity? Okay, so this is the working view for mitral, right? Bicommissural, intercommissural view, lateral, medial. Okay, you can swoop either way to interrogate the valve. Make sure the apex is 6 o'clock. Here, you want to shift the aortic valve towards the right side so your beam is actually encompass the entire tricuspid valve. So now, lateral becomes anterior, medial becomes posterior. And then so this anterior septal sweeping towards posterior septal. Okay, so I'll be inflow view. Okay, so what your corresponding grasping view is going to be your here. Okay, so this is RA, this is RV. Okay, so this is your grasping view. So this is going to be your kind of what we call a reverse 4-chamber view, right? Okay, so your device, when whatever target you're beaming, will look like this. Okay, in the mitral side, once you're steering above the valve, you could be looking like this. Okay, so it's a similar principle. So now, how do we know which leaflet is which? So this is always going to be septal, and then this one is going to be either anterior or posterior, or sometimes we even call it lateral. Okay, because sometimes a quadricuspid valve, so you want to be able to figure out what the lateral is actually more A1 or A2, was A2 or P1, P2. So what I'm referring to is that why you do not know whether it's A or P is depending where your beam is located. So if your beam is more here, it's going to be more A, right? If it's going to be here, it's going to be more P. So that's why when you do the X-plane, you need to see where the beam is happening. You know, unlike mitral, which is pretty much the entire segment is posterior, you just need to figure where it's P1, P2, or P3 to be able to delineate that, right? So, you know, this side will be more P1, this is P3, and of course this will be a classic A2, right? P1, A2, P3. Depends how it cuts across the mitral valve. So the same thing here, and so that's why you need to look at this, but it's very similar. So when your device is down here to grasp, right, your device will be here to grasp like this. So you guys understand to see the parallel between mitral, tricuspid working view? Okay, so we really need to understand as implanter and imager, this is the same equivalent working view to the mitral, so you can draw the parallel, and this is the same view for grasping in mitral, and this is grasping for tricuspid. Okay, so this is really simplified way to think about how you go to grasp. Okay, so now people say, how do you check orientation, right? So let's take a moment, and I'll show you the fluoroscopic view and the on-force view. Okay, so let's start with, echo up top. Okay, so this is mitral again, right? This is tricuspid. So in mitral, we understand the universal 3D on-force, right? Okay. So the commissures here, I usually go 10 and 2. Mitral, as you know, is a smiley face, right? And then we have P1. Let's say this is P2. And this is P3. And of course, there's matching segment here, which is A1, A2, and A3. Okay, so it's very important for the commissures to be here. Now, people asking, well, the aortic valve needs to be at 12 o'clock. That's actually not true because it depends on how the valve relationship between aortic and mitral is. If let's say there's aortic root aneurysm, it's going to shift. And if there's a patient who has a distorted heart, either from previous open heart surgery, this may be this way or maybe this way. So we don't look at the aortic valve. We just need to know the aortic valve is up top. And of course, you know that because you see how the valve looks on the mitral. And so as long as your 3D on-force 10 and 2, you'll know exactly the orientation. So for example, if you're going to grasp A2 and P2, you're going to be in 12 and 6. Okay? If it's going to be more A3, P3, it might be more 11, 5, or even more extreme 10 and 4. And so you basically respect the coaptation line of the mitral valve. Okay, does that make sense? Okay, so if you're A1, the combination would be more like a 2 and 8, or usually maybe 130, 730. So it's very important to respect that coaptation line. And also do not twist the valve. If you clip something like this, that's not good. So that's why if you line up the combination at 10 and 2, you'll always have the same vocabulary and orientation with your imager, so that you say, I'm 12 and 6, I'm perpendicular to A2 and P2, and they'll say, well, you need to either counterclock or clock if you start this way, to this way, and this way. Okay? So now, on fluoroscopy, okay, this is LV, this is an RAO projection now. And so the device comes across like this. Okay, that's the mitral valve, let's say. Okay, so on this view, fluoroscopically, this is lateral, and this is medial. Okay, so you know that if you're going to be more A2, P2 centrally, you're going to be somewhere in the middle. If you're going for A1, P1, you're going to be shifting towards this way with the whole system, or this way for medial. So let's say on the mitral clip system, or even the Pascal system, if you need to do a kind of extra flex, you're going to go more medial, right? But remember, you want to be perpendicular to the coaptation plane, right? You don't want to be doing like this, because then you have a medial dive. So what we're talking about, you want to go in like this, okay? You don't want to go in this way, that's a medial dive, and that's a lateral dive, okay? So if you want to go more target on the medial side, there are two options you can do. If you're already perpendicular, you just bring the whole system, withdraw the whole system, go medial, right? Advance the whole system, lateral, okay? Now, if your trajectory is more lateral, you need to flex or M, right? M knob, to go more central. If it's too much M, then you go less M and go. You don't need to move, advance or pull back. So that's a very important principle to look at on fluoro. And of course, on echo, I'll show you in a moment in the next drawing how that translates. But this is a very important point. And we also, once you optimize your orientation of 3D on false, you go to take the parallax out, okay? Because that means this projection is exactly perpendicular to this. So when you go into the ventricle, if you rotate and spin, you'll note it right away on fluoro, in addition to echo going in on the 2D. All right. So now I'm going to go to the tricuspid side to tell you the equivalence of the same kind of angle trajectory. So tricuspid, because the thinner leaflet, is harder to do 3D. So what we do typically is a transgastric, right? Short axis view. Okay. So typically what you would see, let's say it's a 3-leaflet morphology valve, it's going to be more like that. Okay. So this is septum, septal, this is anterior, and this is typically posterior. Okay, so similar to this, sometimes you can have different morphology, right? Tricuspid valve, we know sometimes 4 or 5 leaflets. So sometimes we can have something here that might be A1 and A2. Okay, sometimes we have small leaflet here. That's the second most common, P1 and P2. Okay? So it's rare to have S1 and S2, and sometimes you have just basically a bicuspid type of valve. So again, when we look at here, it's very important to have the imager give you the orientation of this. And this is also same for replacement as well. So you want to be able to figure out where these commissures are, because let's say for replacement, if you have an anchor here, you know that you're not going to have leaflet insertion on the grasping view, right? Or to look for engagement. So you need to understand where this is, so that you know that you're not going to get, grasping on this plane because there's no leaflets to grasp. So what we need to see here, just like on the mitral side, you can know how to respect the coaptation line. Same thing here. So you're going to respect the coaptation line. So for example, if you're grabbing AS, and this is the coaptation line, you should know in the imager what orientation you are. Okay? And when they show you again with the same view, you should try to reproduce that view. So for example, let's say I'm here, right? This is around 130, 730. You know, let's say you're ready to grasp to go in. And now you want to be able to show that it's the same, because otherwise they said, well, you know, if they rotate the valve, it's 130, 730 is no longer correct, right? You need to kind of shift it according to the actual coaptation line that they're showing you. So it's really trying to show the same image. And so now, for example, in the same language, right, the clock face orientation, so if you're going AS, you're probably going this way, right? PS will be going this way. Okay, we rarely do AP. That's not really what we do. That's been shown not to be effective. But if you think about, if it's, let's say, a quadricuspid valve, right? So we have an A1, A2. Okay, so you would go maybe for A2S, because that's where the jet is. If it's P1's more prominent, then you go P2S. Okay, so you need to communicate with your imager where you're exactly grasping on this transgastric short axis view. Again, you can see it's very much equivalent to the mitral view. Now, on the fluoroscopically, this is now the RV. Okay, this is the tricuspid valve. So now you have the device here. Okay, so now this is posterior, and this is septal, right, anterior. Okay, so AS will be going typically this way. PS will be going typically this way. Now, one reason why we go in RAO view is that once you have the orientation optimized, you should also do the same thing, take the parallax out, so that when you go in, number one, you're going in the perpendicular trajectory. Number two, you want to make sure you have not rotated, because it's very easy to rotate on tricuspid, and you're going to have a tough time grasping because you may end up grasping the canyon or the indentation. So same thing for PS, it will be a different projection in terms of RAO. What you don't want to see is this situation. If you see clip arms, that means you're grasping AP. Why? Because remember, RAO projection, you're looking at this way. The eye is looking this way, right? Remember, the RV is facing you. So if your clip is like this, that means you're grasping AP. You're not at AS or PS. So even though the imager or other people might tell you, oh, you're at the right location, wrong. Okay, because you know on fluoroscopically, it's physically and anatomically impossible to have the arm like this in terms of projection. It will always be either this or this, depending on your target, right? So for example, if it's AS, remember this is flipped upside down, right? So A would be going up there. On fluoro, it would be like this and like this on the LAO view. So let me just show you on a quick here. Very important. Okay, so now let's say an LAO view. So your clip will be more like pointing towards yourself. It'll be A, S, and P. Right? This is an LAO projection. Think about it that way. This is your valve now, right? So septal is here, obviously, because that's the left heart, right? A is going to be here, somewhere like this. Okay. So when it's LAO, your clip should be more or less like this. So that makes sense, right? Without parallax. And this is very important to know if you're doing a replacement procedure, because when you go LAO, particularly they have CIE elites. So if you have the CIE elites, for example, going across, let's give example here like this. Right? You know you're in the PS. So in LAO, your lead will probably be somewhere here. Okay? So you know fluoroscopically you can correspond, so when you kind of start to deploy the anchor, you can check where the anchors are relative to the lead. From here and here, you can and then adjust accordingly on these two fluoroscopic projections. Okay, so you can see that again, the similarity between mitral and tricuspid. For freely unforced view for mitral, right, aortic valve is up top, doesn't matter if it's 12 o'clock or not, as long as you attend to. Okay, and then you do your sweep and orientation check with your device because your arms will be there. That's the best view to figure out where your grasping location is and the orientation. In tricuspid, it's the transgastric short axis view because they're free leaflets at a minimum. And then you need to look at exactly what your target is to be able to adjust in terms of orientation to make sure you don't twist the valve. And so that's the equivalent view. And then fluoroscopically, in terms of where you are, on the mitral side with LV, this is going to be the lateral, medial, and then you have to make sure that you're not having a trajectory bias. You want to be perpendicular, and then you want to take the parallax off the clip or the device, the class device, if you once your orientation has been optimized. Same thing for tricuspid. So you can see that here that AS will be this way, PS will be this way. We rarely do AP. AP will be in the middle, which is definitely not correct. And then you can see also on the fluoroscopic projection, if you want to check whether you're AS or PS, AS will be going towards more this way, PS will be going more downward, and so you can figure out roughly where you are, particularly if you have other devices in place, like a septal occluder, like a mitral device, or even a TAV or aortic valve device. So because all relations are similar. Okay, so that's kind of how we think about this. So let's go back, all right, and look at the echo view. How to correspond with each other. Okay, so going back, again with the mitral side and the tricuspid equivalent, okay? And then we'll do the fluoroscopic equivalent. Okay, so going back again with the intercommercial view, okay? And then here we have the inflow, RV inflow view, and RVOT, aortic valve, okay, this is the LAA here roughly, this is at 6 o'clock, and then you can have your device, okay? So here, your orientation, let's say, is already checked, is optimized, you're ready to go for your grasping. Okay, this is your LVOT view. This is the BICOM, as I mentioned. This is the RV inflow. And this is the kind of reverse 4-chamber grasping view. So here it would be like this. Okay, and then fluoroscopically, this is the RLO projection. The device will be here. Okay, and then here you'll be your RV. Okay, this is AS, this is PS. This is remember lateral, this is medial, and then your device would be, let's say, like that. Okay, so let's assume most straightforward scenario, right? You're already ready to go in the ventricle, so you want to go in perpendicular. That's what I mean, right? So if you go in perpendicular, here you have your device, right? We always like to go in close because you don't want to get entangled with any cords. Okay. So you want to go in centrally and straight. So there are two components, right? Remember, it's a two-dimensional steering. So you don't want to go this way, that's lateral dive. You don't want to go this way, that's medial dive. So if you're going and you're watching, you're seeing yourself medial dive, what happened? You can correct yourself by less M. right? If you're going in and you need to go more medial, but you're going straight, then you withdraw the whole system. Okay, if you need to advance the lateral side, you push in the whole system. And if you see yourself going in this way on your echo view, you have to add more M to go back. Here, this is more about anterior and posterior guide torque, okay? So you should go in straight. If you see yourself going in this way, you need to go clock posterior on the guide. And if you're going towards the posterior wall, you need to counterclock and go anterior to the guide. Okay, so that's what you need to do to do the steering. And this is the same thing as I mentioned before. You want to go straight, right? This is lateral dive, this is medial dive, and you can correct it based on this. If you see yourself going medial dive on fluoro, even though echo is not showing you, you should be able to correct it yourself, okay? Because fluoro is much more high resolution. Sometimes you have artifact, you have some other imaging issues that will compromise your image going in. You should be able to use fluoro to see that. The only thing you cannot see in fluoro is anterior posterior, and that you need to rely on this view. Okay? So now, with the tricuspid, it's a similar thing. Okay? So let's say you're AS, so this is more A, right? This is more P. So again, you want to be able to, and now this is IVC, so you're now here, the device. Okay? So you can see now here, you want to go straight, right? This is a anterior dive. This is a posterior dive. So if the same principle, right? Remember I said that if you're going this way, you have to go more M. If you're going this way, you have to go less M. Okay? Here, the same principle. If you go this way towards the anterior septal commissure, that's no good. You need to flex more. Okay? So flex will go this way on the tricuspid guide system. If you go this way, you need to unflex. So less flex will get you there. Okay? Here, the same thing, looking at this, right? So you want to go in a perpendicular manner. So if you're going towards the anterior septal commissure, you'll flex more, and vice versa, you less flex. This will not tell you whether you're going towards the septum or the lateral. To do that, you need to be able to see this and be able to go in straight. Okay? If you're going more septal, okay, you would counterclock the guide. Okay? Kind of like here, if you're going posterior, you counterclock the guide to go anterior. Okay? So if you're going this way, you counterclock the guide. Okay? Same thing here. If you go in, you're doing septal. This is septal, right? Just to be sure everyone knows orientation. And this is A versus P, right? It depends on where you are. And if you're going anterior here, right? Let me just mark this. Anterior, posterior. Okay? Then you clock the guide posterior, right? To go this way. And you say here. So similar, same principle. If you're going septal, counterclock to go lateral. If you're going lateral, going outside, you clock to go septal. Okay, same principle. Again, same principle here. What I just told you about, this, you go more M, less M, more flex, less flex. Okay? And then now, same thing here, right? If you're going towards anterior septal, you need to do more flex. And then if you're diving this way towards the posterior side, you go less flex. And same thing here, if you go this way, you go more M. If you start going this way, you go less M. Okay, makes sense in terms of how the parallel in terms of views. So again, going back to the mitral valve, just to summarize, in terms of going into the ventricle, in terms of trajectory, you want to go straight down. Okay, this is a bicommissural view. This is lateral. This is medial. Okay, this is going straight. On the mitral side, if you start going a lateral dive, you need to add M If you go in medial dive, you take away M. Okay? Same thing here, same principle, just the knob is different now. So you should go straight, right, into the right ventricle. If you're going towards the anterior septal commissure, you add flex. Okay, if it's going to the posterior, the free wall, you minus the flex so that it moves more straight. And then this is the same as the fluoroscopic trajectory. Same thing here on the fluoro, you should see going in without the clip, without parallax. If you start seeing parallax on the clip, you have rotated and you have to counter rotate to maintain the no parallax. Again, if it goes diving this way, which is lateral, okay, you know to add M to maintain that trajectory. Same thing here. If you going too much, going this way, you need to less M to be able to go straight. And then same thing here for tricuspid, you should go straight. If you're going towards anterior septal, because on fluoro you know that that's anterior septal, you add flex, and then minus flex if you're going this way. Now, on the grasping view, you can't tell on fluoro. So what you have to tell is look at echo. So if you echo, you should be going straight. If you think start to going anterior leaflet, you need to clock the guide posteriorly, right? If you're going towards the posterior wall, you count the clock. Now to the tricuspid is exactly the same principle. If you're doing a septal dive, okay, you count the clock to go lateral. If you're going towards the free wall, the lateral side, you clock to bring it towards septal. Okay, so again, you can see how the parallel in terms of the imaging and the steering of the devices match each other, at least with the system. So now I'm going to actually show you how steering down from the first place work in terms of echo and flow, because that's important. That's how you get the first step to get the device down to do your orientation check and grasping. Okay, so let's go backtrack a little bit. So again, so far as you saw, I haven't really taught you any new views, right? It's only the bicommissure explained for mitral, RV inflow explained, and then on top of that we have the 3D unforce, and then the transgastric view. So but now we're going to show you about the steering on echo and fluoro. Okay. So again, we always stay RAO on our steering. Okay. Just to keep it simple, we're going to show it like this. And this is obviously the valve. This lateral medial, again, same joints. Okay, so this is PS. This is AS. Okay. So now we have this. Okay, this is a septum, obviously. Now the device is here. You already straddle. Here's the little bit different. Right, this is the SVC. So this is LA, obviously. Okay, so now you have this, and you straddle. Okay, so now, what is the echo view that you see? Right, it should be the aortic valve short axis view. So this is mitral valve. This is tricuspid valve. So here you would see in the middle of the aortic valve, you see your septum, and then you see going there. That's a clip now straddle, and then you have your Coumadin ridge here. Okay, so Coumadin ridge. So on the tricuspid side, there'll be the bicable. Right, this is a septum, this is SVC, this is IVC. The device is straddle already right here. Okay. So what we need to show is that you need to clear the Coumadin ridge so you don't end up causing trauma to it. So you will start aiming, right? Initially, you want to have a little bit of anterior guide torque to clear this portion. So you go anterior, and then you go posterior guide torque. So basically, you try to get going this way down to the mitral annulus. Okay, here it's going down to the tricuspid valve, so you need to go this way Okay? So first thing what I do is typically you want to go from negative on the guy to neutral. Right? Because remember, this is tricuspid, right? This is minus first. So when you go minus to neutral, what happens? You're going to have a little bit of a curve, right? It's already getting this way. So on top of that, though, you need to rotate the guy upside down so that you are in that position to start flexing. Okay? So flex is going to go all the way down. Okay? On the equivalent of the tricuspid view. Right? So now you have to do a inflow. Let me just show you briefly like this. So that you see the device coming down this way, while on the reverse four-chamber view, you see this is IVC, remember, it start going this way. Okay? So this is what's going on. When you flex, and then when you count the clock, right, as you flex, and you count the clock the guy, you'll go more lateral, and if you clock the guy, you'll go more septal. Okay, so that's the equivalent, and this is how you know, as I mentioned, when you add flex, this is going to bring you down here. Okay, so that tells, it doesn't tell you how septal or lateral you are, remember that, right? You have to use echo to see that. But this allows you to see. So once you clear the septum, right, this is IVC, this is interventricular septum, interatrial septum. Once you clear this, you can ask the imager, let's go to inflow X-plane view, right? So inflow will allow you to see how much you're flexing. On the floor, you see how much you're flexing, you don't want to overflex. And then on echo, when they do X-plane, you'll be able to see you coming across the valve. So how you see coming across to the in the view of the valve is purely count the clock and clock so that you can get into the view. Okay, that's tricuspid. Mitral is a bit easier, as I mentioned before. Once you clear the Coumadin ridge here and you flex down, you'll see that M down. We call it M down. Okay. When you M down like this, you can ask them to go into your bicommissural view, right? So how does your bicommissural view? You can do a sweep and show you so that you rarely get stuck in the appendage. But you know, when the device comes down this way, right? Once you bicommissural view and then you have your LVOT view, okay, you see where you are here, right? Remember this is A, P, lateral, medial, okay? So now on the bicommissural X-plane, you're Ming this way, right? This is plus M, and you're trying to get it down to here. So when you do the M, you kind of correspond to see where you are. Now you don't know how anterior posterior you are, so you need to use this view. You don't want to be up here, posterior, then you need to counterclock the guy to go back to this center, or if you're too much of a going towards the aortic root, you need to clock to basically be able to see this here. So this is going this way is to clock, going this way is counterclock. Okay? Same principle here, right? Counterclock anterior, counterclock is more lateral or A or P, depending on where you are. And then if you clock, you get more septal. Does that make sense? Because this is the same, again, analogy between echo and fluoro. Fluoro remains the same. The workflow is the same. How you steer down is the same. The view, of course, is different between mitral and tricuspid, but mitral, you do the same thing once you straddle in the LA. The imager showed you this. Make sure you don't hit the Coumadin ridge. You ask them to see it, show it to you, and you, as you M down, okay, and you do posterior guide torque to get into view, you ask them to show you this view so you know how lateral medial you are and how anterior posterior you are. And same thing with the tricuspid, as you flex down, Okay, and then also you get rid of your negative to neutral. You want to be able to do that. Once you clear, you can go to the RV inflow explain view like here. Then you know that you flex down here to get into range, and also you count the clock and clock so that is in the middle. And then once you have that, you saw earlier what we did in terms of discussing the trajectory, optimizing the flow, and then you go ahead and you do the procedure, the rest of the procedure. Okay, so we'll stop here for now, and then we'll see you next time.